Hello. The objective for this video is to explain how to make additions and corrections of an entry in the patient's record. Before we get there are a few things we need to discuss. Documentation. Documentation should present a clear picture of what was found, what was done, and why. It is vital for patient education. We should document any time that we give instruction to patient because this helps us to chart the patient's progress. If the patient comes back and we can see, well, have you done what we suggested you do for your education, as in maybe changing diet or changing exercise, taking the medication, explaining why they have the condition and looking for ways to work with that or to improve. That all goes into documentation because we are able to track progress. Medicare. There are certain guidelines that we must adhere to for federal Medicare guidelines, and it also helps when the company is being audited and reviewed for their documentation. Medical necessity. We've been through the video before where we talked about medical necessity, that if I am being seen for a stubbed toe and the doctor orders a chest x-ray, we need to know why there needs to be a chest x-ray for a stubbed toe. So there needs to be documentation that supports the whatever diagnostic test the physician provider would like to do or any treatment plans. Who are the documenters? Well, that's all of us. All individuals who provide healthcare services may be known as documenters because they chronologically record facts and observations about the patient and the patient's health. Receptionists. Receptionists are documenters because we can document whether a patient arrived for an appointment, any changes for the file. So we are anything that can be pulled for legal reasons, yeah, we're documenters. Insurance department. They have to make documentations in the chart regarding prior authorizations for insurance and for referrals. And also clinical staff. Going a bit further into the clinical staff or the documenters, we are talking about the different types of physicians. Now sometimes the physicians the titles for them may overlap because the attending physician is the one who provides the overall care for this patient. And if a family practice doctor may need to consult with a specialist, let's say a cardiologist, so the patient is being referred to the consult with, the doctor's having a consult with another physician, and then that patient may be referred to the cardiologist. Then we have the ordering physician, the doctor who orders any labs, x-rays, medications, treatment. That would also be the ordering physician. Now the attending physician may also be the ordering physician, and a consulting physician may also be an ordering physician. Then we have the referring physician. This is the doctor that refers the patient out to a specialist. So let's say my physician, Dr. Smith, is referring me to a allergist, Dr. Scott. So I will be seeing Dr. Scott as my allergist. He is the specialist who would be ordering tests for me. And then there's also the treating physician, the physician that is treating any of the problems that I may have. In order to determine what charges to bill, and the proper treatment, the diagnosis. We should all use a standard uh, set of words or phrases that everyone is aware of. Using medical terminology helps in that process. You will find out later in medical terminology it's a whole language in itself. But just like any language, we break it down into parts. And understanding those parts, you can build your vocabulary and you can work in various specialties easily because you know the breakdown of the words. Let's look at the word cardiology. Cardiology. It means the study of the heart and the vessels. It is made up of a combining form or a root word, cardi or cardio, and ology, meaning the study of. So, cardiology means the study and treatment of disorders of the heart and blood vessels. Let's look at polyneuropathy. Seems like a pretty difficult word, but let's break it down. It is broken down into a prefix, a combining form or root word, and a suffix. The prefix, poly, meaning many, neuro, meaning nerve, and opathy, the suffix, meaning condition, disorder, or disease of. So, poly, many, neuro, nerve, opathy, meaning disease or disorder. It is a condition in which a person's peripheral nerves are damaged. So when you start to break down those words and you have a better understanding of medical terminology, it helps us to understand the world of medicine much better. Acronyms, abbreviations, and symbols. Well, there are a lot of things that need to be noted in a patient's chart, and physicians don't have a lot of time, and neither do nurses. So there have been times when acronyms, abbreviations, and symbols may appear in handwritten in a patient's notes because of speed. Well, it should be eliminated from more vital sections of the record, such as final diagnosis, operative note, and discharge summaries and descriptions of special procedures. Now, for your facility, you should have a standard of using any type of acronyms, abbreviations, and symbols. For example, pre-op, that means that's where the person goes prior to going to surgery. I know that in the age where we would have patients' charts near the desk, and sometimes you would see private patient information just maybe on a board. This was before any laws came into play, but a patient may see something C/O/SOB, and C/O would be complaints of, and then you wonder, well, what is COB? Well, for us, in the medical field, it means shortness of breath. But if you're a caregiver to a patient and you're coming in and you're thinking something a little different. So while we were in the hospital, we needed to change that to shortness of air. So it would be SOA. So you can see how using abbreviations could be a bit tricky. And then you would have to learn those abbreviations, because sometimes they're not what you would think they would be, because in this picture here we see QH. Well, what would that mean? It means every hour. Well, where'd the Q come from? So you're just wondering, what do those things mean? Once you learn what is standard for your facility, make sure that you're not making up any new ones, because that could totally mean something else in another department or to someone else. So make sure you know the standard and ensure that it's not included in any type of formal notes. You will also see in documentation illustrations. On this illustration, we see that there is a pain diagram, and the physician may note where the location of a pain would be, where pain would be, and some other notes for that. And you could also use the pain assessment tool with patients, because sometimes when you say from a patient on a pain scale of 0 to 1 or 0 to 1, 0 to 10, how do you feel? And they may go, well, 3 or 4. So having a picture there, and you can say, oh, no pain at all, or, okay, I'm in tears now. This is the worst pain I have ever felt in my life. I am at a 10. Or sometimes, somewhere in between. So having the picture knows that, okay, if I'm crying, there's something definitely wrong. Or if I'm mildly discomforted, I'm okay. I can be mild to moderate. In documentation, you may also see photos. Plastic surgeons use photos a lot to detail the changes that they will be doing in surgery. As you can see in this photo, we see where the man's face has been marked up, and these are areas where the physician may be needing to address when they go into surgery, or even sometimes just injections. You may want to line out where the injections will go for Botox or any other type of treatment that the patient would be receiving. So those images would be in the chart. Measurements. Measurements are how the information is entered into the record. There are various ways the information gets recorded. When we have paper charts, the physician would handwrite the data into the record. This change to electronic dictation or electronic record keeping has saved plenty of nurses, medical staff, physicians from a lot of heartache. I remember a physician in the hospital when I was a unit clerk. We could never read his writing. We would always have to call him to see if what he meant in a certain note or for some orders. So he would get angry because, well, why couldn't you read my writing? But then we figured out that, hey, he's left-handed. Well, if we turned the chart a certain way and then we held it, oh, that says, and it made it much easier to read. But thank goodness when we went to electronic versions of what he needed done, because that saved a lot of time and a lot of calls. Also, the physician may dictate. When they are dictating, then they're speaking into a speaker and you may hear them talk very fast. On the other end of that, the transcriptionist will listen to the dictation and type the information in. Medical transcriptionists, yeah, they are worth their weight in gold, because the speed, now you can slow down the speed, but just being able to pick up on everything that the physician had dictated, it's a gift. It truly is a gift. And we also have the option now that the physician can just key in the data. So the physician would be in the patient's room and they are using the screen to document what their plan would be. Also, you would have a medical assistant. You may often see a medical assistant at the terminal while the physician is actually doing the hands-on work with the patient. So the medical assistant may, or scribe or nurse, may do that part. And we also have order entry, and that would be the computer-based or order entry system. So the orders that the physician needs just input are placed into the computer system. I know when our doctors would say, well, the patient would need to be NPO for the night, meaning nothing by mouth, and normally that's because of surgery. So we would just place the order down to dietary that the patient would not receive a breakfast in the morning and that they would have nothing to eat or drink after midnight because they would be going to surgery. And that would just be put into the computer. The progress note documentation should also follow a format that helps to present the information uniformly and also in a progressive order. One format that we use in the medical field would be, it's called the SOAP note, SOAP, subjective, objective, assess, and plan. Remember that the subjective, what the patient says. Objective, what you observe. The assess and the plan. So we're looking here at a SOAP note, and you see where what the patient says. The patient returns for a scheduled visit following a negative workup for primary causes recently diagnosed hypertension. There's another medical term, hypertension. And so that's what the patient is coming in for. The patient is reporting no new symptoms since the last visit, and we're going through. So then you see where the observation is made because you see what the patient's blood pressure is, and it uses some abbreviations. So it would be right arm and left arm, and it's sitting. And then you would see what the assessment would be regarding the hypertension, and then you see what the plan would be to prescribe medication and then follow up. That is a SOAP note. It is documented subjective, what the patient says, objective, the observations, the assessment, and plan. You may also hear about cheddar notes. Cheddar notes expand on the SOAP note because it goes a little more in depth in some of the categories. We have chief complaint, the history of present illness, the exam by the physician, the details of problems and complaints, and you see here we have drug and dosages, and we have assessment and return to visit or a referral out to be treated elsewhere. Now we're getting to correcting a medical record. Remember when we mentioned that medical records they're used by insurance companies, the provider could be going to court, or the records could be going to court, or if it's for for workers' comp, everything needs to be viewed, even mistakes. So when a mistake is made in a record, never erase it. Never use correction fluid. And do not obscure the original entry. Don't scribble it out. But there are ways to correct a record without doing any of that. When you need to make a simple correction in a paper chart, you will draw a line neatly through the incorrect entry. It should be readable because you don't want to suggest any type of alterations or obliteration of a medical record. Never do that. You may either write or type the correct information where there's adequate space either above or below the line that's being corrected, and write correct, or you can write the word correct or CORR and the date and your initials in the margin of the page. In this example, you don't see the word correct, but you know from the single line, the change of the blood pressure, and the person's signature and date that it is a correction made to the record. We now see that if a little longer correction is needed than just a simple line. So if there's no room for the correction above or below the entry, the correction must be made after the original entry. You enter the date and the corrected data stating correction to a medical record given, and you will put that date. You enter the correction, you sign and date at the end of the notation. Also, if you needed to correct with an addendum or an attachment, let's say the information needed to be corrected after the visit, and maybe it's the next day or a different date, the next day, or something where it can't be easily just documented on the side. So if addendum is needed, you would write the addendum, and it says it's an addendum to an entry on the previous date of the visit. So you would note the original record, where to find the addendum. So you go back to the original record and you can write that piece of information, see addendum, after entry on, and it's given here of October 24th of 2019. And then you would sign and date at the end of the addendum. Now, electronic correction. Electronic, when it works, is much easier than paper, because you still wouldn't delete or key over an original entry. There should be a way in the computer system to edit, and it may do the same thing of just putting a line, and then you would it would offer a way to put the correct information and then your date and initials. Follow the steps of the software program, because each program is different, but it would not delete any part of the record or obscure any part of the record, so that it can still be read. And for the video, we discussed a bit about documentation, and we explained how to make additions and corrections of any entry in the patient's record by never, ever, ever delete an entry, obscure an entry, use whiteout. As a matter of fact, never have even whiteout at your desk. That is a no-no in the medical field. Or, using a heavy mark or a heavy line. No, just a single line if it's written, and then initials and date. But if it's electronic, you would follow the steps in the program to add an addendum or correct any entries. And as you reflect on this topic and prepare to do the rest of the work this week, use this content and the material covered this week, the interactives in your course room, and research using your research of your own using the UMA library and other reliable resources to maximize your learning. Have a great week.